And welcome to chapter 18 on blood vessels. This chapter I condensed into one PowerPoint, so I took 3 and condensed it down into 1. And I really tried to include only the things I want you to know, and I even highlighted some certain aspects as well. So focus on that. So this will be on blood vessels, so arteries, veins, and capillaries. And we'll look at their function and their structure. So blood vessels include the entire delivery system of the dynamic structures that begin and end at the heart. They will work with your lymphatic system to circulate all fluids, blood, lymph. The arteries carry blood away from the heart. It will always be oxygenated, except for pulmonary circulation, where the pulmonary arteries carry deoxygenated blood to the lungs to pick up oxygen, as well as the umbilical vessels of the fetus. Capillaries are in direct contact with our tissue cells. They directly serve cellular needs. So at the capillary level, this is where our blood will offload everything that it's carrying, whether it's nutrients, chemicals, oxygen, pick up carbon dioxide. So that's always at the capillary level, the direct contact with tissues and cells. And then veins carry blood back toward the heart. It's always deoxygenated, except in pulmonary circulation, where pulmonary veins carry oxygenated blood back to the heart after picking it up from the lungs and in the umbilical vessels of the fetus. So you should understand this relationship very well of blood vessels to each other. The relationship between lymphatic vessels and lymphatic capillaries is in the lymphatic system. It kind of it's the catch-all system for excess fluid and waste that will eventually drain into usually the superior vena cava. So that's the lymphatic system. You should understand the structure well of a blood vessel wall. So all blood vessels consist of a lumen, which is the central cavity that contains the blood, surrounded by the wall. And all of the vessels, except your capillaries, have 3 layers or tunics: the tunica intima, tunica media, and tunica externa. I highlight them all because you should know well each in the order that they go in superficial to deep. So the deepest layer is the tunica intima. That's the one that touches the lumen, tunica media, and then the tunica externa is the most superficial layer. Capillaries just have an endothelium layer, so they don't have these 3 wall tunics. They just have one single layer called endothelium with a very sparse basal lamina. So the tunica intima is the innermost layer. It's in contact with the blood. The endothelium is the simple squamous epithelial cells, and the subendothelial layer is the connective tissue basement. The tunica media layer is composed mostly of smooth muscle and elastin. Sympathetic nervous system control will innervate this layer, causing vasoconstriction, decreasing lumen diameter to increase blood pressure, and vasodilation to increase lumen diameter to decrease blood pressure. And this will always be the bulkiest layer that's responsible for maintaining blood flow and blood pressure, because it has sympathetic control by constricting or dilating, which will change blood pressure and blood flow. The tunica externa is the outermost layer, also called the tunica adventitia. It's mostly loose collagen fibers that protect and reinforce the wall and anchor it to surrounding structures. It will be infiltrated with nerve fibers, lymphatic vessels. The vasovasorum is a system of tiny blood vessels found in larger vessels to actually nourish this outermost tunica externa layer. This is a look at what an artery and vein looks like underneath a microscope, and you can kind of see the 3 different layers in each. You'll notice right away that in the arteries, the tunica media is much thicker, and arteries are always usually held open at all times. Veins, on the other hand, are collapsible. They're much thinner. So their 3 tunic layers are just thinner. So veins look like they can collapse a little bit more easily. Here's another kind of difference between the tunica intima, tunica media, and tunica externa layers. Between an artery and a vein, you'll see, we'll talk about how veins have valves in them, and you'll see the capillaries that just consist of these endothelial cells. So they don't have these 3 tunics to them. Capillaries just have a single layer of endothelial cells. And again, the tunica media is the smooth muscle layer. So this is another great picture to kind of test your knowledge and to show how the 3 different layers look a little different between an artery and a vein. This gives you the average lumen diameter size between the different types of arteries. So we'll go through these different types of arteries. Elastic arteries are the largest diameter. Muscular arteries are what most named arteries are. This is where you'll see the large muscle layer. And then arterioles are the smallest diameter of arteries. Capillaries will actually be the tiniest diameter. Only about one blood cell can fit through a capillary at a time. Venules are the smallest veins, and then we work our way up to a normal size, largest vein. So arteries, we divide into three groups that you should know: elastic, muscular, and arterioles. Elastic arteries are the thick-walled with large, low-resistance lumen. Aorta and all of its main branches are elastic arteries. They're also called the conducting arteries because they conduct blood from the heart to all the medium-sized vessels. We'll have elastin fibers found in all three tunics, mostly in the tunica media, and the elastin helps to allow for stretch of these arteries when blood is ejected through them so that they can withstand the blood flow. They also contain substantial smooth muscle, but they are inactive in vasoconstriction. So these are not the arteries that your sympathetic nervous system controls to try to constrict. Elastic arteries will act as pressure reservoirs that can expand and recoil as blood is ejected because they have elastin in them, and this allows for a continuous blood flow downstream, even between heartbeats. Elastic arteries then become a little bit smaller to give rise to muscular arteries. These are called distributing arteries because they deliver blood to all of the body organs. So for example, renal arteries are muscular arteries. Many of them are named for the organ that they deliver blood to. So renal-sized arteries deliver blood to the kidneys. The diameters range from pinky finger size to pencil lead size. And again, these are most of your named arteries that you learned in anatomy are muscular arteries. They have the thickest tunica media with most of the smooth muscle, but less elastic tissue. So these are the ones that are active in vasoconstriction, so under sympathetic nervous system control. And then arterioles are the smallest. Larger arterioles contain all three tunics, but smaller ones are mostly just a single layer of smooth muscle. They will control blood flow into capillary beds by vasodilation and constriction of smooth muscle. And they're also called resistance arteries because changing the diameters of arterioles change resistance to blood flow, and they will lead directly into the capillary beds. Capillaries then are microscopic vessels. Their diameters are so small that only a single red blood cell can pass through at a time. Their walls are just a very thin tunica intima, the endothelial layer, where one cell forms the entire circumference. Pericytes are spider-shaped stem cells that help to stabilize capillary walls, control permeability, what goes in and out, and play a role in vessel repair. And capillaries will supply almost every cell, except for cartilage, epithelial tissue, cornea, and the lens of the eye. And again, the function of your capillaries is the exchange of gases, nutrients, wastes, hormones between the blood and between all the interstitial fluid and tissues. So you should know well the three types of capillaries and what they look like. There will be a pretty lengthy matching question of these three types of capillaries. The three types of capillaries. First, we have a continuous capillary, and these will be abundant in the skin, muscles, lungs, and central nervous system. Continuous capillaries of the brain are unique because they form what we call a blood-brain barrier, where they're totally enclosed with tight junctions and no intercellular clefts. So here we have continuous capillaries. They are the least permeable and the most common. So they form tight junctions. So pericytes will kind of form kind of a seal around these capillaries. So not much can get through, and this will help form the blood-brain barrier in the brain. So tight junctions, least permeable, most common, where they're located: skin, muscles, lungs, central nervous system. So these are continuous capillaries. Fenestrated capillaries then are found in areas that are involved in active filtration, such as your kidneys, absorption, intestines, or endocrine hormone secretion. And they contain Swiss cheese-like pores called fenestrations that allow for a much increase in permeability or allowing things to pass through. And fenestrations are usually covered with a very thin glycoprotein diaphragm. So fenestrated capillaries have large fenestrations or pores, that increase the permeability. So we'll find them in areas of filtration like your kidney, absorption like the small intestine, and other areas of endocrine hormone secretion. So you can see that they have these fenestrations or pores, which allow for permeability into and out of the capillary. So not as tightly bound as the continuous capillaries. And then the sinusoidal capillaries have fewer tight junctions. They're usually fenestrated, but with even larger intercellular clefts or spaces between the cells. Incomplete basement membranes, a large lumen. We'll find these in the liver, bone marrow, spleen, and the adrenal medulla. Blood flow through these is sluggish, and this will allow time for any sort of modification of large molecules in blood cells that pass between the blood and tissue. They contain macrophages, which are part of our immune cells, to capture and destroy foreign invaders. So the sinusoid capillaries are the most permeable, but they occur in limited locations. So we'll only find them in the liver, bone marrow, spleen, and adrenal medulla. They will have very large spaces or clefts between cells. So these are the most permeable sinusoids. Capillary beds are an interwoven network of capillaries between arterioles and venules. Microcirculation refers to the blood flow through the bed from an arteriole to a venule. And the terminal arteriole will always be a branch that forms the capillary bed from an arteriole. And this is where the exchange of all our gases, nutrients, and wastes will occur. Flow through the bed is controlled by the diameter of the terminal arteriole, and we have local chemical conditions and fibers that always regulate the amount of blood entering the capillary bed. So what this means is that the arterial and terminal arteriole will dilate when blood is needed to allow blood flow through the capillary, but they will constrict to shunt blood away from the capillary bed when it's not needed. So here we have dilation where blood flows through the capillaries freely, but then we have constriction where no blood is flowing through the capillaries when, for example, blood might be needed somewhere else in the body. Capillary beds can form a special arrangement of capillaries. We have vascular shunts and precapillary sphincters. The shunt is a channel that directly connects the arteriole with the venule, and it will bypass what we call true capillaries. And precapillary sphincters is a little piece of smooth muscle that surrounds each true capillary that branches off, and it acts as a valve which will just regulate the blood flow into the capillary bed. So here we have kind of the true thoroughfare channel. The true thoroughfare is kind of the true capillary channel. And then we'll have different shunts or sphincters, which will open and close to allow blood to go through the rest of the capillary bed. So they can control the chemical or other stimulation if we want blood to just flow directly through the capillary, or we can allow the precapillary sphincters to open and close to go and fill up the rest of the capillary bed. Then on the other side of capillaries, we have veins, where the veins will carry the blood back toward the heart. They will form from the capillary beds when they unite in postcapillary venules, which are the smallest veins, and then merge into larger and larger veins. So venules, capillaries will unite to form these postcapillary venules. Larger venules have 1 or 2 layers of smooth muscle. Veins then will be formed when venules converge. They will have all the tunics, but much thinner walls with a large lumen compared with corresponding arteries. The tunica media is thin, but the tunica externa is thick. And the large lumen and thin walls make veins a very good storage vessel. So we often call veins our capacitance vessels or blood reservoirs because they contain up to 65% of our blood supply at all time. So here again, I just wanted to show you how the systemic veins and venules contain about 60 to 65% of our blood at all times. So we call the veins our blood reservoirs. Veins then, blood pressure will always be lower in veins than in arteries, so adaptations to ensure return to the blood flow or to the heart are needed. Because blood pressure is always much lower in veins, how can veins work against gravity to get the blood back up to your heart? Well, they have a couple adaptations. We have venous valves, which prevent backflow, and they'll be most abundant in your legs. And then venous sinuses are flattened veins with extremely thin walls. They're only composed of endothelium, and we'll find those in some areas of the heart and the brain. So here we have a valve that will close. Once blood reaches a certain height in that vein, the valve will close so the blood doesn't flow back down. And that just helps to work its way against gravity. So here we have, again, summary of blood vessels, arteries, and veins, and the differences in diameter and lumens. Varicose veins are dilated and painful veins due to an incompetent or a leaky valve. So you'll notice, you can see these veins in the legs when they bulge out because the valves aren't keeping the blood up. The leaky valves allow blood to flow back down, and that makes these veins dilate, become large, and become painful. Factors that contribute include hereditary and other conditions that hinder venous return, prolonged standing, obesity, or even pregnancy, where blood can pool in the lower limbs, weakening the valves, and it can affect more than 50% of adults. Elevated venous pressure can also cause varicose veins, such as straining to deliver a baby or having a bowel movement. This causes intra-abdominal pressure, resulting in varicosities in your anal veins, which can cause hemorrhoids, which can be painful as well. A couple other words, again, I don't highlight things here, but I include them to give you a little bit of background. Vascular anastomoses are interconnections of blood vessels, and an arterial anastomosis provide an alternate pathway to ensure continuous flow, even if one artery is blocked. And this is common in our joints, abdominal organs, brain, and heart. There's none in our retina, kidneys, or spleen. An arteriovenous anastomosis is a shunt in a capillary, and a venous anastomosis is so that they're so abundant that any occluded vein rarely will block any blood flow. So then we get into the physiology of circulation. I'm going to take one more sip of my water. For some reason, I'm really thirsty right now. I probably ate something really salty. So blood flow itself is the volume of blood flow through a vessel, organ, or the entire circulation in a given period. And we always measure blood flow in milliliters per minute, and it's equivalent for the cardiac output for the entire vascular system. It's relatively constant at rest, but at any given moment, it can increase based on one's needs. Blood pressure is the force per unit area that is exerted on the wall of a blood vessel by your blood. And it's expressed in millimeters of mercury, and it's measured as a systemic arterial blood pressure in your large arteries near the heart. And the pressure gradient provides the driving force that keeps blood flowing and moving always from a high to low pressure area. Resistance is opposition to flow, and this will be the measurement of the amount of friction that blood encounters in the walls. And there's three important sources of resistance: how sticky or thick the blood is, that's blood viscosity, the total blood vessel length, and the blood vessel diameter. And this takes you through kind of those terms. And this, I like showing you this picture to kind of show the viscosity of the milkshake traveling through a larger diameter tube or a skinnier diameter tube. And obviously it will flow through a larger diameter tube much more easily. The systemic blood pressure is the pumping action that the heart to generate the blood flow. And this is the pressure that results when the flow is opposed by resistance. Systemic pressure is always highest in the aorta, right when the blood is ejected, and it will decline throughout the arterial pathway. The steepest drop-off occurs in the arterioles, and then we get to venules and veins where blood pressure is always the lowest. And we measure blood pressure by looking at the pressure of the systolic pressure right after the ventricles contract. Then we put that number after the diastolic pressure after they relax. So here we have 120/80, which is normal blood pressure. It's determined by the elasticity of arteries close to the heart and the volume of blood forced into them at any time. And blood pressure near the heart is pulsatile, so it rises and falls with each heartbeat. The pressure exerted in the aorta during ventricular contraction is what we call systolic pressure. And diastolic pressure is the lowest level of aortic pressure when the heart is at rest. And again, normal systolic pressure is 120, normal diastolic pressure is about 80 millimeters of mercury. When we say the pulse pressure, that's just the difference between the two. And the pulse itself is the throbbing of arteries due to the difference in the pulse pressures, which can be felt in various locations on the skin. And I'll show you where you can get those pulse pressure points. Mean arterial pressure is pressure that propels blood to the tissues. And this will be the pulse pressure as it phases out near the end of the tree. The heart spends more time in diastole, so it's not just a simple average of diastole and systole. I go through clinical monitoring of some of these circulatory efficiency mechanisms. I won't ask you questions about them, but you'll learn about them if you go into nursing. So I just want to give you a little bit of an idea here. Vital signs are always the pulse and the blood pressure, along with the respiratory rate and body temperature. So those are the 4 things you'll check when checking for someone's vitals. Taking a pulse can be taken at the wrist, at the radial pulse, but also there's a lot of other pressure points, which are areas on the surface of the skin where arteries are close. And these can be compressed often to stop blood flow in the event of hemorrhaging. So these are different body sites where the pulse is most easily palpated, and you can see those there. Measuring blood pressure is used a sphygmomanometer, say that 10 times fast, and we use it by an oscillatory method for hearing, where you wrap the cuff around the arm superior to the elbow. You increase pressure in the cuff until it exceeds the systolic pressure in the brachial artery and squeezes it shut. Then as we release the pressure slowly, blood starts to squirt through the brachial artery, and we can hear that blood squirting through. Those are called the sounds of corticough with a stethoscope. The systolic pressure, normally less than 120, is the pressure when the first sounds appear as the blood starts to spurt through that artery again as it opens up. And the diastolic pressure are when the sounds disappear because the artery is no longer constricted, so blood flows freely again. Capillary blood pressure, yeah, that's a spelling mistake. It ranges from about 35 millimeters of mercury to 17, so it's very low. Low capillary pressure is desirable because anything higher than that would fracture or rupture the very thin walled vessels. So most capillaries are very permeable, so low pressure will force the filtrate into the interstitial spaces. Venous blood pressure changes little. It's always extremely low. If the vein is cut, low pressure in the venous system causes blood to flow out smoothly, whereas if we cut an artery, blood will spurt out because the pressure is much higher. And low pressure of the venous side requires adaptations again to help that venous blood get back to the heart. And these are more factors to aid venous return back to the heart. The muscular pump is contraction of skeletal muscles to kind of squeeze or milk the blood back to the heart, and the valves prevent backflow. The respiratory pump is pressure changes actually in the abdominal cavity will squeeze the abdominal veins as the thoracic veins expand to kind of force blood back. And sympathetic venoconstriction, under sympathetic control, smooth muscles can constrict, which push blood back toward the heart as well. And here's a look at the muscular pump squeezing the veins with the valves being closed, again, to help blood flow in one direction back to the heart. And then there's lots of factors in how we regulate blood pressure. And this is where I took out some things. We regulate blood pressure by the brain, our neural controls, by hormone controls, and then by renal controls. Your kidney is very important in helping control blood pressure. And if you go to the workshop on, I think it's cardiac cycle or hormones, I think it's the workshop on hormones, you'll read a little bit about the renin-angiotensin-aldosterone system, how the kidney has this really intricate, fun way of helping control blood loss and blood pressure. But we are just going to focus on, so these are major factors that increase mean arterial pressure, but we're just going to focus on hormonal control. So these are some hormones that regulate blood pressure in short-term changes. The adrenal medulla secretes epinephrine and norepinephrine, which increase cardiac output and vasoconstriction. Angiotensin 2 stimulates vasoconstriction, so these will all increase blood pressure. ADH levels that are high enough can cause vasoconstriction. So whenever we constrict a blood vessel, that increases the blood pressure. So these 3 are really important, for increasing blood flow, increasing blood pressure. Those are kind of the 3. But the one that decreases blood pressure is called atrial natriuretic peptide. It decreases blood pressure by just being an antagonist or doing the opposite of aldosterone. So ANP, as it's labeled, causes decreased blood volume and decreased blood pressure, and it's released from your heart. So here's all the selected hormones and the effect that they have on blood pressure. And again, ANP, atrial natriuretic peptide, is the one that will decrease blood volume and decrease peripheral resistance to decrease blood pressure. So then a summary of blood pressure regulation. The goal of blood pressure is always to keep blood pressure high enough to provide adequate tissue perfusion, but not so high that blood vessels are damaged. So for example, if your blood pressure in the brain is too low, perfusion is inadequate, so the person will lose consciousness. But if blood pressure to the brain is too high, the person could have a stroke if something gets clogged, or if there's too much buildup of pressure. A little bit more about regulation of blood pressure, and then we'll finish here. Transient elevations in blood pressure can occur during changes in posture, physical exertion, emotional upset, and fever. So natural blood pressure changes are okay. Your age, your sex, your weight, your race, your mood, and your posture may also cause blood pressure to vary. Hypertension is any sustained elevated arterial pressure of 140/90 or higher. Pre-hypertension will be if values are elevated but not yet in that range. And pre-hypertension may be transient adaptations during a fever, physical exertion, or emotionally upset. And it's often persistent in obese people, so you have to be careful and check your blood pressure. Prolonged hypertension is usually the major cause of all heart failure, vascular disease, renal failure, and stroke. So that's why if you know of someone with hypertension, they are mostly on blood pressure medication, because it will always lead to making the heart having to work harder because there's high blood pressure. So the heart has to push out more blood to get it to where it's supposed to be. The myocardium will enlarge because of that, because it's working harder. It will weaken and it will become flabby. It also accelerates atherosclerosis, which is the buildup of plaque in your blood vessels. Primary hypertension is about 90% of your hypertensive conditions. Risk factors can include hereditary. So that's why whenever the doctor asks, their history of blood pressure in your family, you should tell them, because it might be hereditary. Diet, obesity, age, diabetes mellitus, stress, and smoking. Please do not smoke. Oh, smoking is just terrible. There's no cure, but it can be controlled by restricting salt, fat, and cholesterol intake, increasing exercise, losing weight, stopping smoking, and using antihypertensive drugs. Secondary hypertension is less common. It's due to usually a disorder, including some sort of obstructive renal, artery, kidney disease, or endocrine disorder. Hypotension then, so hypo is low blood pressure below 90/60. It's usually not a concern unless it causes inadequate blood flow to tissues, and it's often associated with long life and lack of cardiovascular illness. So hypotension can be found in the elderly. It can also be found in athletes, extremely low blood pressure. Orthostatic hypotension is temporary low blood pressure and dizziness when going from rising to sitting. Chronic hypotension is the hint of poor nutrition, usually a warning sign for Addison's disease or hypothyroidism. And acute hypotension can be a sign of circulatory shock. And then we go through the types of shock, which I want you to know. Circulatory shock is kind of the all-encompassing idea that it's a condition where your blood vessels are inadequately filled and cannot circulate blood normally. And this inadequate blood flow is dangerous because then it cannot meet the tissue needs for what those tissues need. Hypovolemic shock results from a large-scale blood loss. A vascular shock results from extreme vasodilation and decreased peripheral resistance. And the cardiovascular shock results when an insufficient heart cannot sustain adequate circulation. So you should know those. That's the end of this chapter. Thanks for listening, guys. I'm sorry I haven't been face-to-face. As you saw from my announcement, I'm about 12 weeks pregnant right now. So it's not that I'm just trying to get out of class, but I just have not been feeling well at night. So for the next couple of weeks, we might do the recorded lessons, especially for next week, because next week we'll have your test on Tuesday, and then Thanksgiving you'll have off, and then we'll see how I'm feeling. I hope I feel a little bit better for the last couple of weeks of class. So take care, everyone. I hope you're doing well, and we'll see you next time.